Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today we have not one, not two, but three guests. Two from Chestnut and one from the Illinois Health Practice Alliance. So let me begin with Gilbert Lichstein is the CEO of the aforementioned Illinois Health Practice Alliance, a behavioral health-based independent practice association operating throughout the state of Illinois that counts Chestnut Health Systems as a provider owner. Prior to his involvement with IHPA, Gilbert has operated a variety of residential and outpatient mental health and addiction treatment programs. Second up is Annette Frawley, certified alcohol and other drug counselor and certified peer support specialist in the state of Illinois. Annette currently serves as an IHPA outreach and engagement specialist for Chestnut Health Systems IHPA team. Annette acts as a bridge to community-based resources, championing recovery and wellness. And in the third slot is Molly McVey. She is the Integrated Behavioral Health Care Director at Chestnut Health Systems. Molly has 17 years experience in behavioral health and integrated primary care, specializing in collaborative patient-centered approaches that support whole person wellness. She is passionate about improving access to care, strengthening team culture, and creating sustainable systems that help both patients and providers thrive. Welcome.
Thank you.
Great.
Nice to be
Thank
here.
you. Good morning.
Okay, I'm going to try to be a good traffic cop and keep things running smoothly and in a coordinated fashion. Anyway, again, thanks for everybody for taking the time to join me today. First question I want to ask, but the theme today's conversation is value-based care. And, I know also from our conversation to prepare for this that value-based care means different things to different people. So I want to try, if we can, to arrive at a consensus among the three of you as to a definition of value-based care. So, Gilbert, let me begin with you.
Yeah, the way that I think of value-based care is it's a payment methodology that's oriented towards outcomes rather than the amount of the service that's administered. So, thinking about healthcare settings, it's not so much about how many times you see the person or how many pills you give them or how many procedures, but what outcome exists in their life. And I'll just couch that in a bit of an example for Illinois Health Practice Alliance. We are very focused on the needs of people with chronic and severe mental health and addiction problems, people that are, going to the hospital and emergency department 20 or 30 times in a quarter. That's not a dignified way for them to live. And so what we're trying to do is focus the outpatient behavioral health system on the needs of those individuals so that they can get value-based care early before the condition gets worse and they need a lot of that high acuity care later.
Excellent. Annette, Molly, I want to ask you, but also to ask if there are any misconceptions that people have when it comes to value-based care. Annette, you first, if you would.
So I think for me, value-based care allows me to see the bigger picture of what a person is going through. They may be going to the hospital with a diagnosis of hypertension or substance use disorder. And that might not be the real reason they're there, right? We don't know. We don't know from reading that medical record. So for me, it's about really being able to drill down to what each person is missing, what they need some help connecting with, rather than how many minutes I'm spending with an individual.
Molly, your thoughts?
Yeah, I echo both what Gilbert and Annette are saying. And I think that we can kind of sum that up in thinking about value-based care as ensuring that someone is getting the right care at the right time in a way that really serves them and centers their whole sense of wellness and personhood. And you had asked about misconceptions. And I think one of the bigger misconceptions is that when we are working in a value-based care as a community behavioral health provider, we sometimes feel like we're selling out and working for the man. But being able to really utilize insurance companies and what they are seeing as their needs and helping translate that into what that looks like in real life, and how we make that meaningful for the individuals that we're serving.
Excellent. Okay, now we're going to go in reverse order. I'm going to ask Molly, if you can share specific examples of how value-based care has changed client outcomes at Chestnut, what metrics or stories best illustrate the impact of this approach?
Excellent question. I think that Annette will probably speak to this a little bit better than I do, but from my perspective, what I get to see is the individuals that otherwise would not have ever connected with care, the people that we really see kind of on the fringes of mental health care, substance use treatment, are being able to come into a place that they now see as safe and welcoming. So that's not really it's not really like a quantitative metric, I guess, but it is, something that we can really see in that relationship building component. Overall, hospital utilization, as we see that go down, we then start to see the actual engagement in community-based services increase. So it's kind of this interesting position to be in, to want our numbers to grow rather than to get smaller, which I think kind of gives us a different perspective on care. We also spend a lot of time focusing on that connection between mental health and physical health, and seeing how our individuals start to improve their physical lives by being able to manage and respond better to the mental health symptoms that have prevented them from doing so. So really, one of my favorite metrics is watching people engage in primary care for the first time. So being able to see people come in, actually meet, participate in preventive care rather than only responding to disease management in the future.
Excellent. Annette, any additional thoughts?
Yeah, a little out of character for me to bring metrics to a conversation. But I wanted to talk about one of our members specifically today. He was unhoused. He has the diagnosis of a traumatic brain injury, a seizure disorder, hypertension. He was very difficult to engage with for a long period of time. We actually had to rope the community in to rope him in to engaging with us. But I brought his metrics today because I think sometimes even I forget that this is the end result. So this person 24 months ago had 298 emergency room visits. Let that sink in for a minute. The past 12 months, he's had 44. And during this time, he's become housed. He's starting to access primary care regularly. He's taking his medications, and he's engaging with our team on a regular basis. So in the past 6 months, he's had 5 emergency room visits.
Gilbert, I also want to get your perspective on this. Before I do, Annette, why did you say that metrics kind of isn't your thing?
When I go out in the field, when I make phone calls to connect with people, for me, in my mind, it's not about the metric. The metric will come. The connection is what I'm after.
I mean, that's an amazing anecdote. And we really try to structure this to get out of the clinician's way in terms of capturing these metrics. Those metrics that Annette described, that's things we can see in the claim system. And so part of what we're doing, if you look at the mission statement for insurers, it's to improve the health of members, to improve the health of communities. The mission statements between insurers and providers are quite aligned. And what we're saying is, let's use that quality framework that exists. It's called HEDIS, to track how well the health system is functioning, and let's get providers aligned with capturing some of those HEDIS metrics. And so when we give them data systems to do that, I think before we got here, and Chestnut's really a best practice leader, they were really ahead of the curve on this, but before IHPA was operating, a lot of times behavioral health providers didn't know where they fit into the bigger healthcare context. They didn't know what was going on with the member outside of their four walls. They weren't necessarily thinking about the number of hospital or ED visits. When you see that and you start to think about, to Annette's point, what's really going on with this person, what's the big picture, it starts to look a bit different. Think about how that person's life has changed. It used to be a proposition of going to the ED every day or going to different EDs every day. And now it's moving towards a life that's more dignified, a life that's more like the kind of life they want to live. That's an important part of the picture, is really just aligning mission around these data systems and using these data systems that don't require a lot of involvement from the providers to do the tracking for the outcomes.
Annette, what role does having staff with lived experience in treatment settings play in your ability to reach and engage clients who are typically hard to connect with?
Well, first, I want to say that I'm very lucky to be employed at Chestnut with the specific team that I work with, because I'm given the greatest resource in the world, and that is time. Time to connect with people. That is the number one thing. As far as lived experience, there's a human connection there that exists beyond words. Um, to see the human being in people who are often seen as less than human in our society, and they learn quickly that I am no different than them, even though my life looks a lot different now.
It just occurs to me, when you bring lived experience, is there sort of the other side of this where you could easily be triggered?
Of course, yes. Part of being a person with lived experience is learning how to take care of yourself and your own needs in the moment that you are having that trigger, and having a good support system of clinical staff and other people that you can rely on.
Molly, your thoughts?
So I think one of the common themes that we're already picking up on in what we're talking about is the importance of connection. And there is a really lovely TED Talk and accompanying article by Johan Hari that talks about connection being the opposite of addiction. Like sobriety is not the opposite of addiction, connection is. And I think that that really lends itself very well to thinking about individuals with lived experience and being able to draw from these experiences to recognize that people are just people. Annette has lived experience in one way. I may have lived experience in a different way. And all of these qualities combined is what really enables us to identify the personhood in someone else and that humanness or humanity in someone else, and find a way to connect with them in a different way. When we think about, traditional behavioral healthcare treatment, we're thinking about like this power dynamic between provider and client, and it levels the playing field to recognize either your own lived experience or to intentionally engage people who have lived experience to reduce some of that power dynamic and create that side-by-side approach instead of across from one another.
Gilbert, in the call we did to prepare for this, you expressed your admiration for Annette's approach, and you couldn't put your finger. It was this ineffable, intangible quality. And I don't know if it goes to this question of lived experience, but I'd like to get your thoughts on that, on what you were getting at when you mentioned that.
Well, I'll share something, and then Annette can say whether or not this aligns. I think that having lived experience, it gives you an intuition in these treatment settings that gives you the confidence to do things differently if things need to be done differently. In my experience, that was, when I started doing this, these treatment settings for addiction were more confrontational. It was more about breaking the person down. It really didn't recognize that, this addiction was undergirded by a history of traumatic experience and that the person needed a trauma-informed approach. And I think, I felt confidence to go against that grain because intuitively it didn't make sense. In Annette's example, I think Annette's, and Annette, maybe you can sort of elaborate on the anecdote you shared with us about engaging people. And it gets to what Annette has said in the past about community and what she said about time. But it's an approach that's not taught in schools. It's an approach that you wouldn't know would work unless you had that intuition. Yet it's a singularly effective approach. So maybe, I don't know if you could share a little bit about that engagement process that you told us about before.
Yeah, I was discussing this with a coworker after the call, and what we decided upon is it really is about the little things you don't even think matter, except for they really matter. So we had talked about, becoming part of the community for this member we mentioned earlier, and having lunches with the people in his community and maybe snacking on a bag of chips. And we realized that the little differences were that some people might not appreciate sharing their bag of chips with someone who maybe hadn't had an opportunity to wash their hands in like a week. And they might just give that bag of chips then to that person. No, you can have it. And the difference being, I'm going to eat those chips with you, right? Dirty hands and all. Those little things that don't other people matter.
I think that kind of goes to what Molly was talking about in that TED Talk about connection being so fundamental on the other side of addiction. And obviously that goes sort of a level deeper. Gilbert, when we spoke, you mentioned the quote unquote white glove concierge approach to connecting individuals with resources, which I guess is a little bit different from the shared potato chips approach. From your perspective as providers, how does this model change the way you deliver care compared to traditional fee-for-service arrangements?
I'll speak to it just briefly. I mean, in my career, I've been in a lot of conversations with groups of people regarding a given member, and there's a lot of people admiring the member's problems, but there's not really someone standing up and saying, I'm going to own this. I'm going to make sure that there's a reasonable pathway for the member to get aligned with care. And when you do that, that's when it starts to look like a white glove approach. And that's just a way of describing it that makes sense to some people. But it's really just saying, what is the gold standard for care for this individual? What are the barriers that exist to this individual getting that care? And what is there that we can do within our power to address those barriers?
I agree with that. I think that, when I really think about the systems of healthcare that we're engaging with, they are not easy and they are not accessible. Like, I am a person who has resources. I am a person who works, 8 to 5, Monday through Friday, with the ability to manage and navigate online resources to find the healthcare that I need. And it's still difficult for me, right? Like I can get a referral from my primary care provider and have to call 6 different people to get an appointment that maybe I'll be able to keep. So, when I think about that white glove approach, I really think about essentially just kind of a care partner, someone who shows up and walks beside you to help make that process a little bit more tolerable. Someone who has resources that you don't have access to, that is able to say, it's okay that you can't look this up online. I can. Why don't you come with me? And, just guiding people through a pretty cumbersome process, especially for the individuals that we serve who have such high co-occurring diagnoses or comorbidities, like being able to support them in navigating the very difficult care that comes along with diabetes or other disease processes. So that's really, what I think about and how that's changed our approach to care, specifically in that we don't ever expect or anticipate that our clients are going to be able to do any of these things on their own, not because they can't individually, but because our systems are not set up to support that whenever you don't have access to a lot of resources.
Great. Molly, don't go anywhere because I'm going to ask this question of you. You mentioned just-in-time appointment reminders as part of your access-friendly approach. How does this work, and what other approaches have you incorporated that promote easier access?
Yeah. So with our just-in-time scheduling process, this is something that we started learning about, started implementing probably about 10 years ago now. And, our participation in that varies, but essentially what that does is it removes the like the middle class systems approach from scheduling, right? Like we in a middle class setting are capable and able to schedule out an appointment 6 months, write it on my calendar, get a calendar reminder in 6 months and go to my appointment. That's not a feasible reality for a lot of the individuals that we serve. So just in time scheduling poses that instead of scheduling out, you will get a reminder to call and schedule when it is time for your follow-up. So you're getting that immediate connection with that reminder prompt that is saying, okay, it's time to call and schedule. So then you have like 2 days to forget that you have an appointment or 2 days to remember that you need support or transportation to get to that appointment rather than trying to scramble 6 months from now because you forgot. It really helps support individuals who we serve that are experiencing, a different prioritization of time, maybe experiencing time blindness. A lot of our individuals, especially when we think about individuals who are pretty transient in their community, do not experience time in the same way that you and I experience time. We're only able to focus on the most immediate need in front of us. And if that immediate need is higher in my priorities list than an appointment I scheduled 6 months ago, I'm gonna focus on that. So this helps to kind of reduce competing priorities, help really meet people where they are, and get them in the door when it's time, rather than blocking up somebody's schedule 6 months from now.
Annette, any thoughts or approaches that you incorporate that lower barriers to access over and above perhaps some of the things that Molly mentioned?
Sure. I mean, so I guess the other thing is that there are no hard and fast rules about that. There are individuals that the just-in-time approach does not work well for. And I am able to provide the support they need to get something on the books and get them to that appointment myself, guaranteeing that they keep it. So I think that's it. The other important piece is that it's not a one-size-fits-all. We're trying really hard to know what each person needs and do what they need.
That was one of the things that hit me when I first started in this role, getting to know Chestnut, was that they had really, it was a population health mindset around scheduling. They looked and they said, just clear-eyed, what are we seeing in our data in terms of how we're addressing access needs for psychiatric services and physician services? What can we do better? What are common sense solutions that will address this? And it came from a mission driven approach. It came from a problem solving orientation, but it was a homegrown strategy for boosting access to these services. We have a growth mindset at IHPA. We're trying to move the needle on value-based contracting opportunities, get you guys further into the space on, addressing member involvement with hospitals and EDs and member involvement with integrated care. What opportunities are you guys seeing for value-based care? Like we've talked about scheduling. What are sort of your bleeding edge strategies that you're tossing over for improving member access and integrated care?
I'm very excited about the pilot project. So, we're going to be piloting actually being at the hospitals where most of our members present for care frequently, and building relationships within the hospitals and hopefully catching people before they get to the worst of the worst and using those resources to intervene at that time. And I'm very excited about it.
Same. I'm also super excited about that. I think, probably a year and a half ago, Annette, I might have even been talking to you about my dreams of just like true ED diversion. Like, how can we just be in there and be like, hey, you don't need to be here. I can take you across the street. You can see a primary care provider today. So, I think that that's such a great place to connect with people who are experiencing maybe their highest need in a while, and being able to be the one who says, I've got you, I can support you. Let me educate you about what's out there. And then that flows really into what we were talking about access and just in time scheduling and being flexible and willing to look at what the population needs and respond to that rather than trying to fit our needs into the population. So, one of my roles as a leader is to help people balance the creativity and solutions that we're encouraging them to implement with, competing with a legacy model that is no longer serving us. And help them feel comfortable and confident during that change and encouraging that creativity. And I see that a lot with just-in-time scheduling, because if the provider schedule is completely empty, oh my God, how am I going to meet productivity? Like, don't you worry about it. It's going to fill up real quick because people are going to call when they need to call. People are going to seek services when they are ready. And if we have to say, I'm sorry, I can't get you in today, then that really stinks. That like shuts down that connection immediately. So having that ability to maybe preemptively know what our population needs because it's what we've observed for the past 10 years, and creating space for that. So, another creative approach that we're talking about just in the health center side of things is having an office hours, like essentially just an open hour for providers, for those individuals who show up and are like, I need to see a doctor, but I don't have an appointment. Okay, cool. We've got an open hour right here for you. Come on in. And, that again seems scary and seems different and new. But being able to provide that as a response to an identified community need is really important.
I think concepts that might be new to people are that a lot of times what providers will do in those situations with someone who's not engaged in care, it's that old adage, if you're a hammer, everything looks like a nail. People will lead with treatment. They'll say, well, you've got a substance use disorder. You need to be in an intensive outpatient program. And that is just not what the person is ready to hear. The person has, different hierarchy of needs, and they need different conversation strategies for target behaviors where they're in different stages of readiness. And so this program Annette is talking about, this is funding to give the person help with what we call social determinant needs, which are things like housing, food, transportation, things that interfere with the person's ability to get health care, but at the same time give them buy-in with the provider. And this advancement is really moving more of that decision-making capability into the provider's hands. Molly and Annette are the people sitting in the room with these individuals. They can see when someone's maybe not in the data system signaling that they're a high needs individual yet, but that they're about to be a high needs individual. And so the nuance in this advancement is, rather than relying on our data pool, which says historically, these are the people you should target based on hospital and ED utilization, we're putting it in the provider's hands and saying, based on what you're seeing with the person in the room, do you think this person's at risk for serious health complications if you don't get their needs met? And given that you're in the room with them, they're probably ready to engage with you. So let's strike while that iron is hot.
Gilbert, I want to put this question to you. You kind of touched on this a little bit earlier in this conversation, the inherent tension, if you will, between balancing individual needs of clients, especially those with severe mental illness and substance use disorders, with the requirements and metrics that come from insurance companies in value-based agreements. Talk a little bit about the need and how you go about reconciling that tension.
Yeah, and I've gotten to the point where I don't experience it as a tension, so that speaks to maybe my drinking my own Kool-Aid, but I'll just share some of that Kool-Aid with you. So thinking a lot about how do you build a data system to monitor the outcomes for people with mental health concerns. These don't have biomarkers. So when we're talking about a diagnosis, we're talking about a symptom cluster that's been, developed by a committee of professionals that is assigned based on the member's self-report. It's not like a heart condition or like a primary care issue. And so getting visibility into what's happening with members and how you're moving the needle is difficult. And I think that actually the system that is used to benchmark payers with respect to another, this HEDIS system, is the best system that's out there. It's developed by public health professionals. It's designed to target important public health needs. It It relies on data that's already entering the claim system so that you don't need to burden the providers with new assessments, new questionnaires. You don't need to ask the member again, how they're doing. So I think it's both more accurate and more user friendly. So where that tension sort of disappears for me is that there's just a lot of value adds that you can describe, and I'll use an example. One of our measures is called the FUH, which is follow up post psychiatric hospitalization. It's looking to see within 7 days of a psychiatric hospitalization, did a member have an interaction with an outpatient provider? And you think about what's happening in that interaction. That means that someone like Annette is going and talking to you and saying, what happened in the hospitalization? Did you get your needs met? Do you have a discharge plan that makes sense? Are you able to capitalize on the gains you made during the hospitalization? Do you have other needs? Do you have social determinant needs? Do you have primary care needs? That's all a difference that happens because she's following up based on this HEDIS measure that's built into the insurer's system of tracking how they do. So it's no system is perfect, but I think it's the best system we've got, and I think that it really aligns payers and providers around mission.
Annette, Molly, if you have anything to add to that. If not, now that we have Gilbert as a captive audience, now's an opportunity for you to ask him any questions you may have.
I don't know if I have any questions for Gilbert.
We see each other a lot, so I get to work with these guys. So Annette, we do rounds on members that are experiencing a lot of issues and members that are in programs that we fund, like our on-ramp program, which is this program that gives you the help with social determinant needs. And then we're also a provider-driven organization. So we get people, input from people like, Molly and her peers around how to design our clinical model. And, one thing I'll say is that part of the value proposition for IHPA is really future-proofing behavioral health providers, community behavioral health providers. Not everybody wants to grow and consolidate and become part of some big system. People like what they're doing because it's a fit for their community. And so what we're saying is you can work with us, you can form a critical mass of membership so that you can drive a good value-based agreement, but you can retain your organizational identity. And so we're not pushing down, workflows to these guys. We're just saying, here's where we're trying to move the needle, and help us move the needle in a manner that makes sense to you.
Yeah. Future-proofing. You nicely teed up my final question, which is looking ahead, what do you see as the biggest opportunities and obstacles for community-based organizations like Chestnut and moving further into value-based care models? Molly?
I think honestly, the first thing that comes to my mind when you ask me that question is a statistic that I have thought about for probably most of my career about individuals with mental health diagnosis dying 30 to 35 years before their non-diagnosed or non-experiencing counterparts. And I think that looking at what the whole person needs and being able to creatively and with a level of trust from people like Gilbert and positions like IHPA, being able to help respond to that based on what our community needs are and really help target some of those things. I think the value-based component of that is prioritizing physical health alongside mental health, and looking at where the two connect, because we can genuinely save lives by intervening and helping manage some of those things that are not manageable because of a mental health symptom or a mental health diagnosis. And that doesn't fit the traditional model of mental health care. We've historically in my work, even at Chestnut, who is arguably ahead of the curve in a lot of ways in that integration piece, it hasn't always been that way. A lot of our services are driven by what funders will pay for. And in value-based care, it's different. it provides us that freedom and ability to identify and target things that would not typically fall under mental health care. And that's always been one of my favorite things because I'm able to look at the whole person rather than just that individual symptom.
Annette, thoughts about the opportunities and challenges looking ahead?
Yeah. So as far as challenges, I think that we're still working within a system that's relatively disjointed, right? We don't communicate well between different providers and that sort of thing. But within that challenge are opportunities, right? We're getting more and more technology that can help us with that. Things like we're going to do by being physically present in an ED to build those relationships. Those things are wonderful opportunities that I'm really looking forward to being a part of.
And Gilbert, I'm going to leave it to you to bring this to a resounding close.
Well, I think that these guys are dead on, and I'll just say that we're seeking to operationalize what Molly is saying through a contracting model. So historically, behavioral health providers have been kind of told by the funding entities that primary care isn't your lane. And what we're saying is yours is the door that the members walk through. You're interacting with the person. You have all these skills for engaging them in care. You can do reasonable things to help them get their primary care needs met. What does that look like in terms of an agreement? Well, we're looking at bringing behavioral health providers into contracting models that are typically used by large physician systems in which there's more risk reward around the primary care spend. And we're trying to do this with the people that have chronic and severe mental health concerns. So, leading up to this, we've had a lot of success in driving improvements around these HEDIS quality metrics. Where we're going is more shared risk around that whole primary care spend so that there's more of a financial impetus for providers to do that integrated behavioral health primary care. We know from our data that behavioral health providers can help people make gains with their primary care conditions, and we want to continue along that trajectory.
I have to tell you, at the outset of this conversation, I said I was a little concerned that this may be a little bit awkward. 3 voices in an all-audio podcast may be a little bit difficult to stage manage, may get a little confusing and clumsy. And then when I asked Molly and Annette if there are any questions to put to Gilbert, you said, well, not really. And it turns out because you work closely together on a regular basis, so it was sort of like dealing with a jazz trio. There's that telepathic communication. So it was very nice. So thank you very much. You made this a lot easier than I expected.
Thank
My
you.
pleasure.
Yeah, I like that metaphor. We'll have to make more music.
Absolutely.
I love it.
Thanks so much for taking the time. Today I spoke with Gilbert Lichstein, the CEO of the Illinois Health Practice Alliance, Annette Frawley, an IHPA outreach and engagement specialist for Chestnut Health System's IHPA team, and Molly McVey, the integrated behavioral healthcare director at Chestnut Health Systems. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.